My name's Chadwick Oliveira, and I'm a doctor of physical therapy. This is my presentation for the Therapeutic Pain Specialty Certification done through Evidence in Motion. Today we're going to be talking about some of the key things that providers need to know for treating the chronic pain population. And we are also going to discuss how modern technology can assist with the treatment of this population. So here's the problem. About 1 in 5 adults are experiencing chronic pain, and of that population, 20% are using prescription opioids, which we know are problematic for their long-term care. The healthcare cost is estimated around $500 billion annually for the United States. And within the United States, there are about 250 physicians for every 100,000 patients, or 99 providers for every 40,000 patients. So we're outnumbered, and that's a problem, unfortunately, that is getting worse. Between 2022 and 2050, the patients above 65 are going to balloon from 58 million to 82 million. And just in the last year alone, the Affordable Care Act enrollment has increased from 21 to 24 million. These are the subjects that we're going to cover today in relation to treating the chronic pain patient. They're not given in any particular order, and there's a lot of overlap between all of these, as this is a complex patient population to treat. So we're starting with red flags. Safety should always be our first thing. And if we're looking at what causes chronic pain, it boils down to what the patient's nervous system feels it needs to protect itself. And what typically will occur is the brain comes up with a strategy on how to protect itself that includes pain. This is not the only condition that this sort of thing happens with. I am a veteran as well, and I was diagnosed with PTSD after I got out of the military. And what I learned in my treatment of PTSD was that this is a coping mechanism that the brain develops. Chronic pain isn't much different. It's just a different form of protection. So again, there can be even overlap between the conditions of, say, PTSD and chronic pain. So there's a lot of similarities and a lot of overlap there. And with these red flags, there's a lot. It's complex because essentially every sign and symptom is somehow related back to how the body protects itself and what it determines as a threat, and how it best feels to deal with that threat. If the threat is not known, there's going to be confusion, and fear will start to become part of the problem as well. So for red flags, we want to take these into strong consideration whenever we're dealing with anybody. Again, safety is our number one priority, and these red flags From a physical therapist standpoint, we want to be asking questions about systemic issues, cancers, major orthopedic or neurological issues that we can't necessarily handle. So those are things that if we're properly screening, we then enact in some triage and make referrals to the proper provider to help out with that. And so for those of you who might be listening and are entry level into the healthcare profession, you want to cluster your findings to better give you a more accurate, educated guess, if you will. So not every red flag, sign, or symptom means that you will need to refer out. You can keep the patient with you, depending on the cluster of red flags that you obtain. For those that need referral out, do just that, refer out. But physical therapy has a role in a patient's healthcare, and that's partly what we're going to find as we go along in the presentation. Here's just a few of the most common red flags. And a lot of these deal with cancer symptoms or systemic autoimmune disorders. There's a couple on here that are for mental health and some others that are neurological in nature. Our patients are actually very open to being educated. They're asking questions that they don't have the answers to, and it's imperative that we are able to give them accurate information. So we have to be willing and able to share that information. It has to be relevant, and it helps if it's entertaining. But it needs to make sense, and it needs to be relevant to them. So how long will it take? How much does it cost? There's uncertainty in there. Deep down in there, they're letting you know that they don't know something, that they want to know something, and having something unknown by itself can cause fear, as we will see later on. Helping to answer the question of what is wrong with me and how long will this take, that can vary depending on the factors. If we're dealing with a nociceptive injury, that being your typical injury that one may encounter, the popular one that we hear is just stubbing your toe. Okay, well, falling down while running is another thing that can cause a nociceptive injury. And that could be anything from a scraped knee to a broken bone or a torn ligament. These are your, this is the stuff that at entry level you can feel confident in treating, because these are going to be your acute injuries. And this is where chronic pain starts. We know that most injuries will heal in about 3 to 6 months. And if pain lasts beyond that time period, there's increased likelihood that you may be developing a central sensitization or the nociplastic pain. That's just one of the signs that transition might be happening. With nociceptive pain, you can treat that the way we were classically trained to treat that. A little bit of rest up front, let the body rest and recover, but we need to get you up and going again. There's some contraindications, some red flags, if you will, depending on the orthopedic injury. So not all nociceptive injuries are going to be treated the same. And that is to also include post-surgical events. Your peripheral neuropathic pain, these are injuries that are directly involved with the nervous system. If the nervous system sustains damage, this could vary from sprained ankle to a pinched nerve root, radiculopathy. So these things will take a little bit of time because, again, most tissues heal in that 3 to 6 month time period. And there's really a big window in there as to how long these treatments can last. If we are able to identify a nociplastic pain, there really is no telling how long that could last. However, we do know that because of neuroplasticity, you can see changes as early as day one, and you can start making progress towards the goal of pain relief as early as day one. However, you're playing a long game, and the patients should know that. They should know that this type of pain is not a light switch, and that there's processes that we have to take the person through so that they can have a good understanding of what needs to happen for them to get better. Promoting self-care. We are always going to be promoting self-care, and it's important. We, as healthcare providers, we're coaches, we're guides, we're mentors. We're there to help people help themselves, and that can sometimes be a hurdle for some patients who come to us expecting us to fix them. And this is where the stages of change starts to come into the conversation, because if they're in pre-contemplation and are not willing to change, then our role as a healthcare provider is to plant some seeds and help them hopefully move to the contemplation stage. And there we can have a little bit better prognosis of success. But we're not here to force somebody to get treatment. We're here to provide them treatment and meet them wherever they are. We can lead a horse to water, but we can't make it drink. Our purpose is not to do these things for the patient. They have to see that they are in the driver's seat and that they're the ones who are in control. For those who are in chronic pain, they would benefit from as much movement as they can possibly do. And that's going to look different for everybody, because everybody's nervous system is a little bit different. Some are going to be more sensitive than others, and we want to meet them where they're at and then start to help them have small increases in progress. We're going to talk about fear for a little bit. It's a basic, intense emotion aroused by the detection of imminent threat, involving the immediate alarm reaction that mobilizes the organism by triggering a set of physiological changes, according to the American Psychological Association. What I tell my patients when I'm starting to educate about pain is that we look at pain as a protector, and it's an option that the brain has to protect us. The brain does this with a lot of things, and this is not to discount the role of the nerves that are out in the body, but the brain is the one that makes the decisions, and the brain is the one that writes the scripts and can ultimately write new scripts. So if we give into the fear, that's going to make us more sensitive. If we continue that process, we end up in some very bad places. What we give up for protection is freedom and our happiness. The brain has safety on its agenda. That is the priority. So let me back up for a moment here. There's a lot that can be said about it, and I'll put it this way: the same way that I've been sharing it with my patients is, we don't forget how to ride a bike. That sits on the shelf and it might collect dust, but that script, that playbook, that recipe on how to ride a bike stays there. And unless you suffer some catastrophic brain damage, it's going to be there still. So the brain will write the same types of scripts, playbooks, recipes for how to protect you. And if that involves fear and pain, the two are a volatile combination. If we fear pain, we stay sensitive. If we ignore pain, we stay sensitive. So we don't want to fear or ignore pain. We want to respect pain. And how I explain this to my patients is, let's say this is your pain threshold and this is your sensitivity. Now, yes, it's true that the threshold can change somewhat, but it's way more likely that the sensitivity is going to change. Okay, and so if you're experiencing pain for a long time, that adds stress onto your system. If you're getting different explanations, you might be confused or starting to get scared about what's going on. That's going to make things more sensitive. If you haven't slept in a long time, that's going to make things more sensitive. Problems with work, at the home, everything's creeping to raise that sensitivity up. And then when you ignore pain, it triggers the alarm system, and it takes a long time to settle down, and it settles down right back to this sensitive spot because it knows you're going to do it again. Fear, being the protector that it is, keeps you sensitive without ever going up to the pain threshold. And so if you fear pain or ignore pain, you end up sensitive. So we want people to start respecting pain. Go up to it, back off, up to it, back off, up to it, back off. So one fear that we all have is the fear of the unknown. And this is a fear that really lies underneath all the layers of questions that the patient is asking us. What is wrong with me? They don't know what's wrong with them. How long will this take? They don't know how long it'll take. Excuse me. And so that fear of the unknown is something that could be at the very core of what's keeping them sensitive. And education will reduce that confusion, and it will reduce that fear. And once we help them identify the problem and what it'll take to get this problem under control or to rehabilitate them, they feel better. They will feel at ease. Their pain will still be there, but they will at least have some confidence and some awareness of, hey, I've identified the problem and I now have the ability to start treating it. And so education could be one of the things that helps to start getting our patients to see success early on. That can happen on the first day at the initial evaluation. You teach them about their sensitive nervous system and then start showing them how they can take steps to lowering their nervous system sensitivity. We can take some advice from other people out there who are helping with different types of pain. Someone like Dave Ramsey has his debt snowball effect. Okay, so you tackle the smallest problem first, and you keep going, devoting your energy to the next smallest problem. And oh, by the way, you're making your minimum debt payments on everything else. What are the minimum debt payments for somebody who has pain? Well, you got to be doing all the things that your body needs to help recover from an injury or an illness. You got to be getting good sleep. You got to make sure that you're hydrated, that you're eating well, that you're doing a little bit of exercise, that you're managing your stressors. Those are all the minimum payments. And then you devote your other available resources to the smallest problem, and then you get success when you deal with that problem, and now you can direct all your focus to the next problem. Well, some of these problems that they have might be with doing the minimum payments. Like, what if they're not eating well, or if they're not sleeping well? Well, that's a small problem that can actually have a big effect. And, some people would even say it's a big problem, and I would even agree with them. But that's something that you can have a lot of control over and help make some progress on early, is getting your business in order, if you will. Our physical exam needs to be with the appropriate use of tests, critical thinking, the ritual of the patient and provider interaction, the appropriate amount of touch, and having honest conversations about the results and the interventions, sitting down and having the patient be an active participant in creating their goals. outcome measures, functional outcome measures, subjective outcome measures, all of it is useful. And again, you want to cluster things. I've been finding that the use of the central sensitization inventory has been wonderful at helping me to confirm and identify my patients that I have with central sensitization or nociplastic pain. I've been including a pressure algometer into my manual assessments as well. And I really like that as an objective measure over pressure pain thresholds, as opposed to the joint mobilization grades of 1 through 5, because I have no idea exactly how much pressure I'm putting for a grade 1 or a grade 2 or a grade 3. You're going off of essentially provider and subjective outcomes at that point. And so the pressure algometer is something that I have found has been a useful tool with gauging just how sensitive their nervous system is to touch. And in terms of walking, walking is one of the first things that we can get most patients doing, and to help them with aerobic exercise and movement, which are things that they need to start getting better. So doing things like the tug or a 2-minute walk test, those are great baseline tests to help measure and improve function. We want to minimize any additional treatments or contacts with medical personnel. When I was in the military, we were taught to deal with problems at the lowest level possible. And that's really something that I think is lacking in the civilian world. There's a lot of people that don't know how to deal with problems. And some small problems can feel like big problems because they don't know how to deal with those problems. So that's what we're here for. We're here to help them see the problem for what it is and help them with getting better at dealing with that problem. Know when to ask for reinforcements. And this goes back to our red flags, our triage, our stages of change. We're looking at a lot of different things, trying to properly categorize, identify patterns in the patient's behaviors or their signs and symptoms. And we might need to refer out for more testing or for additional medical or psychological treatments. Our bread and butter as physical therapists is to assess and assist the recovery of general physical fitness. This is what we get trained to do on the entry level, and other healthcare providers are great at assisting us with that. And this is our basic goal for helping people to recover from pain. Helping them with creative outlets. Many people who are experiencing pain stop doing things that they enjoy doing. They might see that as a barrier because they experience pain, and they will isolate because of it. this is problematic because it's good to have socialization and to engage in creativity. And really, if the neuromatrix, the playbook or the recipe for protection doesn't include creativity, and you're very focused on protecting yourself, you're not going to have room for creativity in your life. And so helping people to get back to being creative is super important for their recovery. So now, how can technology help us? Artificial intelligence and social media are two things that are not going away. And if we don't get comfortable with using these things, we're going to find it more and more difficult to accomplish our tasks. And so artificial intelligence, what it does is it provides us leverage in condensing the time that it takes to do the things that we already do. It can offer us some additional things like language barrier, like overcoming language barriers. The majority of what I'm going to advocate that we use it for is to help us with our creative outlets for making videos like this, and even having sort of brainstorming sessions that can help with coming up with different stories. Let's say, for instance, you have a patient who's an electrician, but you don't know anything about the electrician occupation. Well, you can pull up an AI like ChatGPT and give it a prompt, something like how to relate pain to an electrician. Okay. And it could give you a list of ideas to help make your explanation for pain relevant to that person. And some of them are not going to be good. You're going to have to use some critical thinking skills, and you decide which one would best fit. So artificial intelligence is ultimately going to help us learn faster and be able to deliver better stories faster as well. Now, what about what artificial intelligence can't do? Artificial intelligence doesn't really understand the nuances of human language. There's body language and irony. There's no way for an AI to develop a therapeutic bond. It can't, because it doesn't have the ability to share real human experiences. I've found this to be a particular advantage of mine because of my history with PTSD. I don't tell everybody that I have PTSD, but when I feel that it's appropriate and that it might be useful to help me get some rapport, then I will share that side of me with my patient. And that is something that's been a very useful skill that I have. And I would encourage really anybody to try to empathize as best you can with your patient. If you can't empathize with them, then at least be kind. We want to be not just good providers, but good people too. One last thing to mention about what artificial intelligence can't do is that it does not provide stable references. And what I found with doing this project is that the way to reference an AI is to treat it like you're interviewing somebody else. And just like interviewing somebody else, you should fact check them and have other credible sources available to back up what the AI is saying. And these unstable references are very similar to an expert not having all the knowledge needed. So let's say, for example, you ask the AI how to do hamstring strengthening exercises, and you want the AI to list them from easiest to hardest. Well, it might give you a list of exercises and stretches, and what it's doing is it's pulling things from the internet the same way your brain would be like, oh, okay, so we could do hip extensions and bridges, but the AI is also pulling things like stretches, and stretches are considered an exercise for some, but in our profession, it's a stretch. It might be a movement exercise, but you need to clearly define what exercise means. If you're going from from easiest to hardest, then a stretch might be somewhere towards the beginning, especially if it's just a movement exercise. But if you're talking about a muscle strengthening, stretch might not even be on the in the conversation. So we need to be mindful that the AI hallucinates, and in a way that is similar to how our brain kind of fills in gaps of information where it's not known. So social media is able to help us by giving us a megaphone and a platform with which to spread our message out to more people than the one-on-one interaction. And one of the great things about social media is that it allows anybody to post things onto the internet. Unfortunately, that's also the downside. It allows anybody to post anything on the internet. And because everybody has the ability to post things on the internet, there's a lack of oversight and a lack of fact checking. And this is really an argument for why healthcare professionals and educated people should be on social media, should be using AI to assist us, so that we are combating the false information that might be out there. And some of the information that we might consider false, it just might be outdated. And the rate at which new evidence is coming to light is not slowing down. It's not slowing down because of social media and AI. It's only getting faster. And one of the things that we learned from the pandemic is that science is messy. There's a lot of back and forth, and the public got to see that happen in real time, and we all got to see how much confusion that left everybody with. So really, when you look at how many people support the use of social media in professional education, professional health education, there should be a lot more healthcare professionals online sharing their knowledge and experience and helping to reduce confusion and fear. We need to be learning from others that are already on social media and using AI. I learn from others on YouTube how to record, how to use AI, and I follow some other doctors online that are already doing these sorts of things. One in particular is Dr. Andrea Furlan. She's a medical physician out of Canada. And she puts out videos about teaching chronic pain and other medical stuff as well. Her videos are very informative and very well done. She is doing great work, and she's inspired me, as well as some other YouTube creators have inspired me. And so that's what I intend to do going forward with this information and this skill set that I have. There it is. My presentation on the key factors that for treating chronic pain, and my references are here.